You're watching the latest edition of the Wellness Hour, the leader in medical news and information. I'm Randy Alvarez. Today's topic, what you need to know if you are considering breast augmentation. My advice, stick around for the latest edition of the Wellness Hour.
The Wellness Hour, an in-depth discussion with today's top physicians and medical leaders. And now, your host, Randy Alvarez.
You're watching the latest edition of the Wellness Hour, the leader in medical news and information. I'm Randy Alvarez. My first guest is Dr. Stephen Zucker. Dr. Zucker is the founder of Plastic Surgery Center in South Bend, Indiana. We've invited him on the program today to discuss what you need to know if you are considering any type of breast surgery. Dr. Zucker, welcome to the program.
Thank you for having me on your show.
Good. Now, before we get into today's topic, tell us a little bit about your practice. By the way, I've been told you're the go-to guy for breast augmentation.
Right.
But you do more than that.
We do it all, Randy. I've been in practice in South Bend, Indiana for 23 years. We do facial plastic surgery. We do breast augmentations. We do breast reductions and reconstructions. We do injection fillers for wrinkles, Botox, Restylane. It's pretty much a comprehensive, all-inclusive practice.
So your background, your training, board-certified plastic surgeon.
That's right. I did all my training in the Midwest. University of Michigan in Ann Arbor. I did my internship at the University of Wisconsin in Madison. Did complete general surgery training at University of Iowa in Iowa City. Back to Ann Arbor again for plastic surgery training.
Did you always know you wanted to be, I mean, when did you know you wanted to do plastic surgery?
I made up my mind to become a plastic surgeon when I was a scrub technician at University Hospital in Ann Arbor in the very early 70s. The team there was headed up by Dr. Reed Dingman, very famous name in plastic surgery.
Okay.
And the professors there made a deep and lasting impression on me. It was pivotal in my decision making, really. I was kind of under the totem pole. I was hired to pass instruments, but I remembered everybody I met, everything I saw, and I went back there for my professional training.
Okay, now your staff, you know, one of the things I liked about you on the telephone, because everybody always says, I have a great staff, but you, I mean, you believe it.
Oh, I really do.
And they've been there a long time.
From the beginning, I'm very proud of my employees. I've got the best. I hired Bobby as my office manager. She's been with me for 21 years. Barbara has been my transcriptionist for 20 years. My nurses have worked with me for 15, 16, 18 years. We have very little turnover. It has made for a lot of stability, and that pays a benefit to the patient.
Why? How so?
Because they enter a smoothly running, well-oiled machine, a good system.
Interesting.
That hit the ground running 20 years ago and continues to this day. And all of my people know what they're doing. They know how to talk to patients, how to make them feel good from the beginning. The patient, remember, goes to you for a reason. And if they come in and they sense that the people there are practiced and polished at what they're doing, it immediately gives them a very deep sense of comfort, and they like that.
Now, your surgeries, where do you do your surgeries?
We do all of our cosmetic surgery on site in the office. I built Plastic Surgery Center with a view toward taking the cosmetic surgery out of an institutional setting and putting it in a private setting where we could control the quality, lower the cost, and keep it on an individual one-on-one basis.
Moving on to today's topic, breast augmentation or breast surgery, I say. What are the different categories of patients you see for breast surgery?
I think of my patients basically as presenting in two different ways. There is the younger woman who comes in before children, and then there's the patient who comes in after children. And things change, as all of the women know. Our younger patients tend to be students or young professionals. They're healthy, they're motivated, and they're active socially. They want to look good in clothing, fill out a blouse and bra to good advantage, and have their appearance complement their shoulders and their hips.
Are the patients getting older and older, or are they getting younger and younger?
There are those patients who come in after they have raised their children, and that's the second category of patients. That's the lady who's raised and probably breastfed 2, 3, 4 kids, and she comes in and typically says to you, I want my breasts to look the way they did before I had kids.
All right.
And so there is sometimes a little, shall we say, retailoring that needs to go along with that. The typical plan has a few challenges to it. There's issues of size, symmetry and droop. And the symmetry and the droop is usually what comes out as time goes by.
Let's start there. How do you decide size? A woman comes in on a consult. What happens?
You listen, basically. And I like to say to my patients, tell me in your own words, what do you hope to get out of this operation? What do you want it to do for you in practical terms?
Well, isn't that obvious? They just want to be a little bigger?
No, it's not at all obvious.
Okay.
And what the important thing to remember is that what I may think is obvious isn't necessarily obvious to the patient. You have to put yourself in their position.
Okay.
They are likely a little shy about the whole thing, feeling just a little bit intimidated, and you have to draw that information out of them and then give them the spur to talk, and then listen very carefully to what they say.
On the consult, you mark them up a little bit?
All of them.
Are you taking measurements?
Yes. I measure from the collarbone, from the breastbone. I measure from the crease up to the tip of the nipple. And that tells me where the nipple is. It tells me anatomically where I want it to go. And it tells me how much soft tissue I have to work with. And that's when we begin to look at the dimension of the implant and fit the implant to the patient. In other words, I have to have muscle, I have to have skin, I have to have a certain amount of fat, and I have to line it without having a tight fit. And that is how you define your framework. That tells you what you have to work with. And then you begin to think and explain to the patient, do we have the wherewithal to set this up the way you want it?
Do they bring in their partner, their spouse?
Hopefully they do.
Oh, really? Hopefully.
Sure. Because you want them to go home to a supportive home environment where somebody is there to help them take care of themselves.
Okay.
And if their partner isn't happy, then she may not be happy. And you want to make sure that you're doing this for the patient, not for the partner, of course. But it's always best if they come in with a supportive home background. And we always ask that to make sure that they've got somebody who can fix them a sandwich, bring them their pill, help them with a bandage, take them by the elbow and bring them up to the table. That's all important.
As far as advances in breast surgery, anything new in the last 20 years, or I'm sure, what is new?
I think the biggest, latest development has been the reintroduction of the newer silicone gel breast implants. The older product, I think, was basically a good product, but it was not studied enough. It wasn't controlled well enough. And since 1990, the whole subject has come under a great deal of scrutiny, and it's all been for the better, because the newer product is a better product.
Why is it better?
It's better.
And you're talking in terms of a gel-filled or silicone?
Correct. That's
Okay.
right.
And why is it better?
It's better, I think, because the industry has come up with something that doesn't break up. And actually, I can show you.
Sure. Let's take a look. So what are we looking at here?
This is a new silicone gel breast implant. It's a smooth, round product.
Okay.
And if you take it in your hand,
Right. Okay.
you can see it has a certain softness.
Yep.
And this is a saline-containing implant, which is empty. It is a good product too, but this is a newer development.
So is one is more like a water balloon, and one is more like flesh tissue. This feels like flesh.
That's
Fleshy.
right, and it has a soft contour. That's
Okay.
that's what makes it appealing. Now they each have their advantages. We can get the saline implant through a slightly smaller incision. They tend to feel perhaps just a little firmer. The newer gel implant requires a slightly longer cut, perhaps, but it is a softer feeling implant.
Is that your implant of choice, though? Silicone or gel filled?
The implant of choice is what the patient wants.
Okay.
Whichever one they feel more comfortable with is probably the better call.
Of
And
those
we use
two,
them both.
does one look more natural than the other?
No, I don't think so. I think it's
the
more in
feel-
terms of feel.
But the silicone feels more natural.
That's right. It's softer, basically.
Tell me about, and anticipating this interview, talk to some women about this, and some strong opinions about where, in the armpit, I guess, in the fold, through the nipple area, through the belly button. What are your suggestions?
Most times we go in the fold underneath. That bears directly on how much skin they have to work with.
Okay.
Many times women are a little bit plumper at the bottom, what we call the lower pole, the bottom of the breast, right where it joins the chest wall. And that's a great place to put an incision because it heals well, it blends in with the skin texture lines nicely, and it gives you good exposure. Technically speaking, it's a useful incision to make.
Is it the best one to hide the incision?
Depends how much soft tissue they have.
Okay.
If they have just a little bit of excess or a little redundancy, it oftentimes will gather down at the bottom and do a wonderful job of covering an incision in that area. Now, by contrast, if you have a woman who is very, very little developed and her skin is tight, oftentimes the nipples are paradoxically just a little bit large, then any incision you put on the chest wall is going to show, and it's going to be difficult to cover. That is an excellent combination of characteristics, features, to make an incision at the edge of the nipple where it blends with the white skin of the breast.
What about the sensation when you go in through the nipple area?
Occasionally, it can happen. But more, I think, that happens by making an overdeveloped pocket to take the implant. Now, the other incisions that you hear about and everybody knows about, the incision in the armpit. I used to do that. I've become less enthusiastic about that one.
Okay.
It's summertime. People are getting ready for the beach, and they oftentimes will be in sleeveless tops, don't really want an incision in the top of the armpit, and it's hard to work with. It's harder to control the size of the pocket and the level of the implant. And so I've gotten away from that. And I must say, I don't have any respect for that.
You don't like it at all. You have strong opinions about this.
I do not want, I would not consider an incision through the umbilicus.
You think it's a mistake? Oh, in the belly button area?
I'm not, no. I respect the incision in the armpit. That is a worthy approach, and there is something to be said for it. I've just gotten away from it. I really don't have much respect for that incision through the belly button.
Not at all?
No.
Think it's gimmicky?
Yes.
Is anybody even doing that in Indiana?
I don't know.
Okay.
I can tell you I'm not.
Okay, all right, all right. How much art and I told you, my impression was it was pretty straightforward breast augmentation, but how much art, how much science, if you had to put a percentage on it?
Sure. There's art and there's science. I don't really know how to break it down except to say that you have to appreciate both when you do this. And really, I can show you that.
Yeah, let's take a look.
Here's a good place to start. This is, I guess you could call this a quote-unquote average case. If you look at this patient, you see that she is rather underdeveloped. And in the post-op photo down over here, look at the soft curve she's got at the bottom of the breast. And over here you see that shadowing. Shadowing gives you depth.
Shadow under the breast.
And dimension. It shows you that a change has taken place. Flat surfaces don't give you shadow.
So when, in your mind, a great breast augmentation is one that
looks natural.
Okay.
It doesn't have an
straight ahead
quality. It blends with the rest of the patient and it flows with her anatomy.
So you are in control of that part underneath the breast.
You're in control of all of it, but you have to be sensitive to what you have to work with. So you take the patient's best features and you bring it out. Let me show you another photo. Many times my patients will ask me about cleavage, and that's really mostly genetics, but working within that, you do have an influence. You can help that. And if you look at this lady's picture, you can see the shadow that she's got, and you can see the reflection of off the front of the breastbone. And notice the space that she's got here and the narrower space that she's got here. You have to work in that soft tissue envelope.
Do you dig in a little bit there? Is that how you're doing it?
No, you don't dig. But you do release the muscle close to the breastbone, and you take care not to over dissect them toward the side. You don't want it rubbing on the arm. And that's when it helps.
You can do something about cleavage. Because
you can do something about it. But you always have to remember that you work with what the patient gives you.
Are you aggressive when it comes to cleavage?
When I have to be.
All right.
All right. If that's what's called for and if that's what she wants. Not everybody wants that. And truth to tell, they can probably get more cleavage out of their choice of bra rather than their choice of implant.
All right, now these are very natural. Everything you've shown me so far
you always want
is very natural.
You want soft curves, plump contours, and you want to avoid sharp edges. I'll show you another.
All right.
This woman retains her basic shape. She's a little fuller toward the side. We say laterally, but that means toward the side. And now she's plumper down below. She has something for her bra to pick up. And we've taken the level of the nipple and we've projected it forward. And this is another one, and I want you to pay attention to the bottom. Notice how plump she looks without being overcorrected. You see that depth of dimension, the shadow against the chest wall, the round, plump contour, and the way she flows together naturally.
So
you don't see any sharp edges either.
Yeah, now you mentioned the shadow, so just a nice hang to the breast.
Correct. Yeah,
and so you control that.
Yes, you do.
As a surgeon. Okay.
You control the plan.
It's a natural look. All right, we're going to take a quick break. More photos and the process, what people can expect, the downtime, and we'll move on to the lift, the breast lifts that you're doing as well. Okay. You're watching The Wellness Hour, the leader in medical news and information. I'm Randy Alvarez. We're here with Dr. Zucker, and we're discussing what you need to know if you're considering any type of breast surgery. We'll be right back. You are watching The Wellness Hour, leader in medical news and information. I'm Randy Alvarez. We're here with Dr. Zucker, board-certified plastic surgeon, and we're discussing what you need to know if you're considering any type of breast surgery. Okay, before we move on to the breast lifts, and you have some photos of that.
Right.
You have more photos. What are we looking at here?
I want you to pay particular attention to this one, because this is a particularly large implant, and yet she doesn't look overcorrected. This is a woman who wanted to place the emphasis on size, and that's fine. The side shot, what we call the lateral, particularly shows how full and plump she is over the lower pole, and how that curve runs into the side of the chest very smoothly with a natural contour. Some people do place a premium consideration on size. Okay. That's their first and their most desired characteristic. And provided it is a safe thing to do, then I don't mind giving them what they want. This is a lady who requested a particularly large implant because she liked the full rounded look. To her, aesthetically speaking, that was desirable, that was pretty. Notice that she really doesn't hang in a plump fashion. Mostly what she has is projection. She projects
a straight ahead look.
Straight ahead look. And she's rounder over the upper pole and overall larger. That is what the patient found attractive. That's what she asked for. And
but you lean more toward a natural looking breast.
Yes, but that's not what I want is less important than what the patient wants.
All right, okay.
Provided, of course, it makes sense surgically and it's a safe thing to do. This is another one. This is, in some ways, a little bit of an exception to the rule. This patient's a professional dancer and works typically with a brief costume and quite muscular. Okay. Young, athletic woman who did not want the impression of her muscle to show off by compressing the implant. And because her family history was satisfactory in terms of breast cancer, we went on top of the muscle, not under the muscle. And
so you are
that's
saying
the exception, not the rule. But
for somebody that's like dancing or whatever, you're saying that the implant will show more, oftentimes on a lean, athletic person, if you put it under the muscle.
Correct, because their muscle is strong, and when they move their arm, it pushes down and out. And if you see that, most unattractive. This is also another way that I like to do it when we can, and that is to make an incision around the edge of the nipple. Notice that's virtually indiscernible. Okay. It blends very well, and for the lady with the right anatomy, it is oftentimes the procedure of choice. It works very, very well.
What are their fears? When they go to you, are they afraid? What are they afraid of? Is it that the incisions will show? What is it?
It's just a general lack of familiarity, sort of a fear of the dark, until you kind of take them by the hand, explain the process, explain the recovery, and let them know that we have their concerns in mind. Plastic Surgery Center was put together to take the intimidating aspect of a surgical institution out of the plan and make people feel individually well cared for. It is one-on-one doctor care, one-on-one nursing care. Patients don't want to hurt, they don't want to be separated from their family, and they don't want to feel sick. And we've got a plan for all of that. We're very liberal with pain control. We have a new device called the OnQ pain pump, which actually trickles local anesthetic into the interior of the wound and does much to lessen their pain and discomfort. And if you don't have to use narcotics very much, then they have much less nausea too.
How soon can they go back to work? Or do you hear stories of them going back to work?
Generally, the recovery time is about 2 weeks when they're going to be taking it easy. I have the sutures out by 3 weeks, and by the way, I suture everything internally so it doesn't leave external track marks. And between 3 and 6 weeks, they can gradually increase their level of activity, getting back to exercise and athletics by 6 weeks. And here's yet one more. This is a lady middle-aged who opted for a fairly generous-sized implant, and I made my incision underneath, and that's what she's showing you here. If you look carefully as she lifts the breast,
you cannot see the incision.
Very, very difficult to discern.
That's not touched up.
It's not touched up. This is about a year post-operative.
Now we're just about out of time. Breast lifts.
The lift has to be taken into consideration, particularly with older patients who have completed their family raising. The changes of pregnancy bring along with them weight gain, weight loss, skin stretching. And if you only put in an implant, you're not going to hit the nail on the head. This is a lady who came in and presented with considerable droop. And the side shot, I think, brings it out to best advantage.
Yeah.
Look there, and notice before, here is the crease. This is where the breast descends, and this contour is brought out by her rib. Now, after she's recovered from the operation, you don't see that anymore. But where the implant is giving you the best improvement is right behind the nipple. Basically, we've eliminated the droop. We've put the implant under the muscle, behind the breast, behind the nipple, all in phase, all lined up well, and taken care of the problem of small size and lift specifically and directly.
So the incisions, though, on a lift, they always have to go in the front of the breast?
No, they don't. It depends on how much droop the patient has. We gauge droop in terms of the position of the nipple with regard to the crease under the breast. For minimal droop, we oftentimes can release the base of the breast, put in a generous implant, and that's all you have to do.
All right.
Greater amounts of lift, I may take out a little crescent or half moon wedge on top of the nipple, bring it up a small amount, done. This is a woman who had a lot of droop, and we basically cut completely around the nipple, moved it higher on the chest, higher on the breast, and retailored the skin in 2 directions. Now, she's only 6 weeks out. The scars look a little pink,
so
but I'm showing you this
they fade over time pretty well?
Sure, sure.
Those aren't bad. Going into this, it seems like they'd be much worse.
The scars are narrow and tight, as you would expect at this point, and I would expect her to fade a lot by 1 year. Now, we put them on sun protection. We make sure that they use sunscreens, and oftentimes we'll do the operation in the fall months, particularly if they work outside, so they're nicely faded by the following spring. There's lots of different ways that you can individually plan this for the given walk of life or the patient's specific needs. I want you to see that the nipples are smaller. Mm-hmm. With regard to the scar, it's all below the nipple, and it is not going to show in a V-neck blouse. And the horizontal scar is nicely concealed by the little plump overhang of the rest of the breast. Many times people are a little shy about wearing revealing clothing, and it's very reassuring for them to look at exemplary photos like this, and be able to see that all of the incision work is below the nipple, where it's very unlikely to show.
Now we are out of time. Things we haven't talked about, I guess, breast reductions.
Breast reductions are common. I'm a breast surgeon. We do a lot of breast reductions. And it's a very rewarding operation because you can take a patient who is very uncomfortable, bra straps cut into her shoulders, she gets low back pain from chronically leaning back, and has skin irritation from perspiration. Literally overnight you can take those patients and make them
Is that right?
more comfortable. And of course I brought an example to show you.
Okay, let's take a look.
This is a young woman. Now if you look at this, you can see that this patient is not overweight, but her breasts are very, very large. And particularly in the preoperative photo, I think you can see in the photo, get an impression that her shoulders are back. She's trying to compensate through her posture for the weight of her breast pulling her forward. And that's a very uncomfortable situation. In the post-op, you can see that she's not small-breasted.
Great job.
Not small-breasted by any means. Her scars are nice and fine and narrow, but she's unweighted. Now she's comfortable. And it's common for patients to comment on the first day after their operation how much better they feel.
Is that right?
Yeah.
Now, so young and old, I mean, for the breast reduction surgery you get weekly, very common procedure.
It's a common procedure. It really is. And patients know about it, and they're not shy about asking for it.
All right, final message to a woman, I guess, that's just not happy with their breast size or their breasts? What do you say to them?
Come in for consultation, because many times patients just don't know what can be done, don't really know what they need, or may have the mistaken impression that they need an implant when they really need a lift, or they may need both. Consultation is readily at hand. And
do you do all your consults?
Yes. And so I don't delegate that to an assistant. The patient needs to have the operative plan put together by her operating physician, and needs to have her questions answered the right way the first time. And afterward, I work with nurses in terms of patient education. But the initial consult is something for me. That's my job.
So do you consider yourself a perfectionist?
I wouldn't say perfectionist. I think this is a job for a peak performer. If you're a perfectionist, your results are always falling short of perfection. It's not a very rewarding position to put yourself or your patient in. I like to be a peak performer. I like to do my best all the time.
All right.
That's achievable. You can